Selamat pagi Bapak dan Ibu sekalian. Saya ucapkan selamat datang dan terima kasih atas kedatangannya di forum kajian pembangunan di SMERU. Topik kita hari ini adalah Interdistrict Differences in Correlates of Health Workers Absenteeism yang akan dibawakan oleh dua orang pembicara kita, Ibu Wayan Suriastini dari SurveyMETER dan juga oleh Bapak Jeffrey Sine dari RTI Internasional. Sebelum kita mulai, ada beberapa titipan pesan dari tim panitia. Jangan lupa bagi Anda yang ingin menyebutkan tentang acara FKP ini di sosial media untuk mencantumkan hashtag IndoFKP. Kemudian Anda juga diharapkan untuk bisa menjaga dan memperhatikan barang-barang pribadi milik Anda sendiri karena seminar ini terbuka untuk publik. Presentasi dan tanya jawab dalam seminar akan dilakukan dengan dua bahasa, baik bahasa Indonesia maupun bahasa Inggris. Jadi jangan khawatir bagi peserta yang ingin bertanya, nanti boleh menggunakan kedua bahasa itu. Dan yang terakhir, technical things. Untuk keperluan video streaming, baik peserta dan pembicara nanti akan diminta untuk menggunakan mikrofon supaya terdengar suaranya. Baik, untuk mempersingkat waktu, saya akan langsung persilakan para pembicara untuk mempresentasikan. Silakan Pak, Ibu Wayan.
Terima kasih Bu Emi. Saya akan karena ada sesi diskusi tadi, mungkin saya akan langsung presentasi dalam bahasa Indonesia. Ininya nanti Pak Jep akan.
Kamu bahasin, saya bahasin.
Oke. Ya. Terima kasih banyak Bapak Ibu sekalian atas kehadirannya pagi ini dalam acara seminar pagi hari ini. Pak Asep, terima kasih banyak atas atas kesempatan yang diberikan kepada kami untuk mempresentasikan hasil penelitian ini. Dan ini merupakan studi bersama kami antara dengan Pak Jeffrey Sine dan juga dari RTI Internasional dan juga dengan Firman Witular dan Dani Alfa dari SurveyMETER. Dan ini bisa kita lakukan dengan support dari data yang dikumpulkan pada saat studi dengan pada saat USAID kinerja project yang dari Papua. Terima kasih sekali untuk pihak USAID kinerja Papua atas data yang sangat-sangat kaya ini. Terima kasih sekali. Nah, presentasi pagi ini akan kita bagi menjadi 4 bagian, artinya ada 4 subtopik yang kita akan bahas. Yang pertama terkait dengan studi konteksnya seperti apa, kemudian terkait dengan sampel dan metodologi yang kita pergunakan, kemudian hasilnya, dan terakhir kita akan membahas tentang bagaimana penggunaan dari hasil ini dan kemudian implikasi daripada hasil dari studi yang kita lakukan ini. Nah, pertama tentang konteks dari studi ini. Jadi studi ini seperti saya bilang tadi bahwa menggunakan data yang kita kumpulkan untuk terkait dengan proyek USAID Gereja Papua, di mana USAID Gereja Papua Project itu tujuan utamanya adalah bagaimana memperbaiki kualitas dari pelayanan kesehatan yang ada di sana lewat perbaikan dari inovasi daripada pengelolaan tata kelola pada segmen manajemen, misalnya terkait dengan manajemen daripada pelayanan kesehatan yang ada di Papua. Nah, seperti diketahui kemudian absenteeism ini adalah salah satu faktor yang kemudian diketahui sangat mempengaruhi kualitas daripada konsep pelayanan daripada pemberian layanan kesehatan yang ada dimanapun, bukan cuma di Papua, tapi di berbagai belahan dunia ini. Nah, untuk melakukan intervensi untuk mengurangi tingkat absenteeism ini, maka kita perlu mengetahui dulu apa sih akar permasalahan yang menyebabkan kemudian absenteeism ini terjadi. Nah, ini oleh karena itu kita lakukan studi ini dilakukan di 4 kabupaten kota yang ada di Papua yang merupakan wilayah kerja dari USAID kinerja Papua, yaitu 1 di Kabupaten Jayapura, kemudian Kota Jayapura, Kabupaten Mimika, dan Kabupaten Jayapura. Nah, hasil ini kemudian, dari hasil itu kita akan mengetahui ya, apakah kemudian penyebab daripada absenteeism ini adalah sama antara setiap kabupaten kota ini atau mungkin berbeda Nah, kalau berbeda tentunya kita perlu mendesain kemudian intervensinya berbeda juga untuk setiap kabupaten dan kota. Nah, apa yang kemudian kita hasil dari studi ini kemudian dipergunakan untuk memformulasikan sebuah intervensi lewat kemudian kita adakan dialog dengan pemangku kepentingan. Kita sampaikan hasil ini kepada pemangku kepentingan, kemudian pemangku kepentingan berdiskusi. Kita memfasilitasi kinerja Papua, hasil kinerja Papua, kemudian memfasilitasi kemudian diskusi itu untuk memformulasikan kemudian yang apa yang kita sebutkan operational policy barrier analysis. Apa-apa kemudian desain-desain intervensi yang akan dilakukan berdasarkan hasil temuan yang dari studi ini. Nah, studi ini kita lakukan tahun lalu pada bulan Mei sampai dengan bulan Juni tahun 2014. Nah, secara garis besarnya, secara umum ini studi ini mempunyai 4 tujuan. Yang pertama, ingin mengetahui kemudian tingkat rate daripada absenteeism yang ada oleh petugas kesehatan untuk 3 kategori. Pertama adalah dokter, kemudian yang kedua adalah perawat dan juga bidan. Yang kedua tujuannya adalah untuk mengetahui perspektif daripada absenteeism dari sisi petugas kesehatan. Bukan itu aja, tapi kita juga ingin melihat bagaimana kemudian dari sisi persepsi daripada kepala puskesmas, health center ini, bagaimana persepsinya dia. Dan berikutnya kita bukan cuma berhenti dari sisi pelayanan kesehatan dari sisi supply-nya, tapi kita juga lihat dari bagaimana persepsi dari pengguna dari fasilitas kesehatan tersebut. Dalam hal ini adalah anggota masyarakat dan juga tokoh masyarakat. Kita lakukan juga. Jadi ingin mendapatkan informasi persepsi daripada bukan cuma absenteeism, tapi juga bagaimana terkait dengan pelayanan yang diberikan oleh puskesmas. Yang terakhir kemudian tujuannya adalah menggunakan evidence ini, data hasil penelitian ini untuk memformulasikan operational policy atau intervensi yang dilakukan untuk mengurangi absenteeism itu sendiri. Nah, konsep framework yang kita pergunakan untuk studi ini adalah seperti terlihat di dalam gambar sini, bahwa ada 4 komponen yang mempengaruhi kemudian tingkat ketidakhadiran. Ya. Salah satunya adalah komponen pertama adalah terkait dengan karakteristik daripada individu itu sendiri. Yang kedua adalah bagaimana lingkungan daripada di sekitar daripada puskesmas itu sendiri dan juga lingkungan daripada di mana dia tinggal, si petugas kesehatan sendiri. Yang ketiga adalah karakteristik daripada fasilitas kesehatan sendiri dalam hal ini keadaan dari puskesmas itu sendiri. Yang terakhir adalah juga yang menentukan adalah bagaimana kemudian dari lingkungan daripada kebijakan, artinya institutional policy dan gimana keadaannya secara institusi seperti apa kondisinya. Nah, ini yang kita coba lihat dengan ini. Nah, sampel frame daripada studi ini adalah semua puskesmas yang ada di 4 kabupaten kota ini. Yang jumlah totalnya keseluruhan itu ada 57 puskesmas yang ada di 4 kabupaten kota ini. Tapi yang kita masukkan dalam studi adalah hanya 50 karena 3 diantaranya kita pergunakan untuk pilot, ya, karena kita mesti melakukan pilotnya juga. 3 itu juga puskesmas kita yang ada di Kabupaten Jayapura kita gunakan untuk pilot. Jadi 1 perwakilan yang ada di kota, 1 perwakilan yang tengah-tengah, 1 lagi yang cukup jauh remote dari kota, dari remote lokasinya. Kemudian ada 4 puskesmas yang ada di Kabupaten Mimika yang kita nggak masukkan dalam studi ini karena kemudian sangat-sangat terpencil sekali. Kalau pergi mencapainya kita mesti menyewa helikopter, mesti biayanya mahal sekali. Kemudian belum yang kita diputuskan pada saat diskusi, oke, kita nggak masukkan dan juga sudah ada perwakilannya dari beberapa tempat yang lainnya. Jadi sehingga kita akan hanya pada saat studi ini mengunjungi 50 dalam studi ini adalah 50 puskesmas yang kita wawancarai. Kemudian untuk petugas kesehatannya kita mulai dengan mendapatkan daftar dari petugas kesehatan yang ada di puskesmas yang kita akan target kita itu dari dinas kabupaten kota dari kabupaten kota. Dari Dinas Kesehatan Kabupaten Kota. Jadi listnya kita ada dari sana. Karena kita turun bulan Mei, jadi itulah versi yang bulan April yang kita peroleh dari Kabupaten Kota. Seperti itu. Kemudian dari daftar ini, dari daftar yang kita dapatkan dari Dinas Kesehatan Kabupaten Kota, kemudian kita lakukan verifikasi konfirmasi pada saat kunjungan pertama kita ke Puskesmas, kemudian kita konfirmasi secara verbal. Apakah kemudian kita cek lagi orang-orang ini masih ada nggak, petugas kesehatan ini masih ada nggak, masih ada di situ dan juga hadir apa tidaknya. Kemudian untuk pada tingkat komunitas, ini adalah kita lakukan 100 fokus grup diskusi, yaitu 50 diantaranya fokus grup diskusi untuk laki-laki, masyarakat yang laki-laki, dan 50 lagi adalah yang perempuan. Jadi satu puskesmas ada 2 fokus grup diskusi, 1 untuk laki-laki dan 1 untuk perempuan. Dan kita juga melakukan wawancara mendalam untuk tokoh masyarakat. Hanya saja untuk presentasi pagi ini kita tidak menggunakan informasi dari komunitas ini, tidak menggunakan data dari kualitatif tadi ini, tapi sebenarnya sangat kaya sekali. Kami juga ingin informasi sangat-sangat kaya sekali dan benar-benar jernih sekali. Jadi perspektifnya, pandangannya beda sekali dengan apa yang kita peroleh dari sisi kemudian petugas kesehatan ataupun kepala puskesmas yang ada di sana. Ini sangat kaya sekali. Nah, inilah detail daripada sampel kita untuk petugas kesehatan. Nah, jadi kita pergi ke 50 puskesmas yang ada di 4 kabupaten kota tersebut. Nah, yang kita wawancarai adalah untuk dokternya, kita lakukan sensus, kita wawancari semuanya, baik yang hadir maupun tidak hadir pada saat kita kunjungan pertama. Demikian juga untuk bidannya, kita lakukan sensus, kita wawancari semuanya yang ada di 50 kabupaten kota tersebut. Yang kita kemudian lakukan sampling hanya untuk yang perawatnya. Yang perawatnya kita lakukan sampling secara random, yaitu untuk yang petugas yang hadir pada saat kunjungan pertama kita, itu kita yang tidak kita announce ya, kita tidak umumkan, itu adalah 2 per puskesmas. Kemudian untuk yang tidak hadir, yang absen pada saat kunjungan yang tidak kita beritahukan itu 2 juga. Kemudian yang untuk ada juga sejumlah perawat yang pada saat kita berkunjung itu mereka ini sedang ada shift yang tidak sedang tugas pada saat itu, atau sedang bertugas melakukan pelayanan ke posyandu misalnya untuk yang di wilayahnya puskesmas. Nah seperti itu kita lakukan sensus untuk mereka. Kita mereka nggak hadir pada saat itu, tapi kita lakukan sensus, kita bagi menjadi 3 bagian. Nah, saya lupa mengatakan tadi bahwa untuk mereka-mereka yang tidak hadir pada saat kunjungan pertama itu, yang pada saat kunjungan kita pertama, kita lakukan men-tracking mereka. Kita mewawancarai mereka di rumahnya ataupun kita berkunjung lagi ke hari pada waktu lain kalau misalkan mereka kita buat janji kapan kita bisa lakukan wawancara untuk mereka-mereka yang tidak kemudian bisa kita yang tidak hadir pada saat kunjungan pertama tersebut. Nah, completion rate-nya itu adalah yang tertinggi adalah untuk yang bidan, yaitu mencapai 98%. Untuk yang untuk perawat yang hadir itu 98%. Kemudian yang kedua adalah untuk yang bidan secara keseluruhan. Ini kita kelompok, maksudnya kita jadikan satu karena sensus, kemudian baik yang hadir maupun tidak hadir totalnya itu sekitar mencapai 97%, ya, completion rate-nya dari target kita. Kemudian untuk dokternya itu mencapai 93%. Sedangkan yang terendah itu adalah untuk perawat yang tidak hadir dan juga yang kemudian pada saat kita kunjungan tidak hadir tapi sedang melakukan tugas pelayanan di luar puskesmas, misalnya ke posyandu dan lain sebagainya. Nah, itu mencapai sekitar 87 sampai dengan 88%. Nah, ini perbedaan rate antar kelompok ini ditentukan karena proses yang tadi itu untuk menemukan mereka-mereka yang absen tidak hadir pada saat kunjungan pertama itu cukup sulit, walaupun kita sudah paling tidak teman-teman pewawancaranya udah mengkontak mereka, mencoba mengkontak yang target kita untuk yang tidak hadir pada saat absen pada saat kita berkunjung itu adalah sudah lebih daripada 3-4 kali seperti itu. Dan kita juga melakukan proses trackingnya. Kadang-kadang mereka juga ada di luar kota cukup lama, misalnya di luar Jayapura kadang-kadang. Misalnya sedang cuti untuk melahirkan di Makassar atau di luar provinsi, seperti itu contohnya. Nah, untuk instrumennya kita punya 3 level instrumen. Yang pertama untuk pada level Puskesmas. Pada level Puskesmas ini mengumpulkan informasi untuk roster. Jadi daftar dari petugas, daftar singkat keadaan daripada semua petugas kesehatan yang ada di Puskesmas ini. Jadi kita kumpulkan informasi terkait dengan karakteristik daripada petugas kesehatan itu sendiri, yaitu kita kumpulkan informasinya. Salah satunya adalah terkait apakah hadir pada nggak hadir pada saat kita berkunjung pertama kali ini. Jadi ini adalah untuk roster ini kita tidak memberi informasikan kepada Puskesmas bahwa kita akan hadir pada waktu itu, seperti itu. Ya, kita tidak, ini nggak diinformasikan mereka. Kita administrasikan roster ini pada jam 9.30 sampai 10.30 di antara jam tersebut. Dari hasil pilot kita, kalau kita lakukan sebelum jam 9.30 itu banyak yang petugas kesehatan belum hadir. Nah, kalau kita lakukan jam 8 teng itu bisa semuanya nanti 100% gitu, karena belum ada, baru pintunya aja yang dibuka soalnya. Cuma ada yang membuka pintunya itu adalah apa namanya, driver daripada ambulannya soalnya, kemudian yang lain-lain belum ada. Jadi kita wah kalau kayak gini 100% semua jadinya yang tidak hadir. Kemudian di satu tempat kita datang lebih awal, satu tempat lagi kita datangnya emang bukan nggak sebenarnya kita nggak bermaksud demikian seperti itu, tapi kemudian karena kita baru selesainya satu tempat di satu Puskesmas itu siang sekali, jadi kita pergi satu Puskesmas yang lainnya itu udah pada pulang semuanya seperti itu, hampir 90% udah mulai pulang, jadi setelah jam 10.30 begitu, jadi udah hampir semuanya hilang. Jadi nggak mungkin kita lakukan kalau misalnya kita tidak tentukan waktunya, jadi tidak tentukan waktu kunjungnya untuk roster ini untuk mengetahui apakah hadir tidak hadirnya, akan sangat apa namanya, membingungkan sekali nanti kalau terlalu Puskesmas ya satu tempat kita kunjungin awal sekali jam ini, kemudian kalau pas apa namanya terlalu terlambat setelah jam 10.30 akan jadi berabe juga nanti pada kita akan bertengkar hanya karena masalah waktu kunjungan yang berbeda-beda untuk setiap Puskesmas. Jadi hanya kita putuskan bahwa ini adalah mengetahui hadir tidak hadirnya adalah pada periode waktu jam 9.30 sampai dengan jam 10.30 seperti itu. Pada kunjungan pertama ini benar-benar kalau mereka lebih awal datangnya, mereka kan belum wawancarai petugas wawancaranya seperti itu. Jadi belum mereka akan wawancarai roster ini seperti itu. Jadi mereka akan nunggu dulu sampai jam 9.30 sampai dengan 9.30 di antara waktu itu. Nah, inilah waktu yang kita melihatnya bahwa pada saat itu petugas kesehatannya, petugas dari Puskesmas ini ada hampir semuanya seperti itu ya, udah ada pada saat itu memberikan pelayanan. Nah, ini kan kita tanyakan untuk konfirmasinya bukan langsung ke petugas kesehatan tapi ke kepala Puskesmas seperti itu. Nah, untuk pada tingkat dari Puskesmas ini kita kumpulkan informasi juga tentang secara detail tentang karakteristik daripada kepala Puskesmasnya. Jadi kita punya khusus untuk terkait dengan kepala Puskesmasnya. Bukan cuma keadaan demografinya, pendidikannya, tapi juga kita tanyakan persepsinya dia tentang bagaimana kemudian tingkat daripada absenteeism di Puskesmasnya dan hal-hal lain tentang intervensi apa yang mereka lakukan dan sebagainya. Kemudian kita juga mengumpulkan informasi, melakukan asesmen tentang keadaan daripada Puskesmas itu sendiri pada level Puskesmas. Kemudian yang level kedua lah kita mempunyai informasi untuk petugas kesehatan itu sendiri. Jadi kita tidak hanya memiliki yang roster itu, tapi kita memiliki data yang lebih yang lebih detail tentang Puskesmas, petugas kesehatan yang tadi, yang hadir maupun tidak hadir. Ya. Jadi kalau yang dokter kita sensus. Ya kita dan juga bidang sensus kita punya informasi individu dari setiap petugas kesehatan yang dokter dan yang hadir tadi ya, yang dokter dan juga bidan. Tapi yang untuk yang perawatnya kita punya tadi sampling. Jadi 2 untuk yang hadir dan 2 lagi yang tidak hadir, dan kemudian yang sedang melakukan tugas di posyandu tempat lain kita lakukan sensus. Nah, ini kita mempunyai informasi yang lebih detailnya. Ini data informasi inilah kita pergunakan nanti dalam studi dalam paper kita. Kemudian pada level komunitas kita punya instrumen untuk fokus grup diskusinya dan juga untuk in-depth interview. Nah, dengan data yang kita kumpulkan ini, kita mempunyai kesempatan untuk mengukur tingkat absenteeism ini untuk dua hal, untuk dua keadaan. Yang pertama adalah terkait yang kita sebut dengan cross-sectional absenteeism. Ini adalah dari informasi kunjungan kita pertama kali tadi. Kunjungan kita ke Puskesmas ini pertama kali yang kita tidak umumkan itu. Ya, nah inilah kita lakukan, kita seperti saya katakan tadi bahwa kita dapatkan list dari dinas kabupaten kota, dinas kesehatan kabupaten dan kota, kemudian kita konfirmasi, kita tanyakan kepada kepala puskesmas atau yang senior yang mewakili di situ. Kemudian kita tidak hanya percaya kepada informasi dari kepala puskesmas saja tentang siapa yang hadir nggak hadirnya pada saat itu, tapi kita juga melakukan observasi langsung, dengan langsung juga mendatangi ruangan-ruangan dari petugas kesehatan itu. Ketemu, oh ya, yang siapa namanya bidan A, seperti itu. Kita lihat bidan A itu yang mana ya, seperti itu. Jadi kita punya, ya ada kolom variabel yang mencatatkan kemudian hasil observasi kita ini. Sehingga yang kita pergunakan lah untuk menghitung absenteeism itulah dari hasil observasi kita. Tapi kita punya persepsi dari informasi yang dari pengetahuan ataupun informasi pernyataan dari kepala puskesmas ataupun yang wakilnya, seperti itu. Tapi yang kita pergunakan adalah yang kita dalam analisis ini adalah yang dari observasi kita, benar ada apa tidaknya. Kadang-kadang ada beberapa hal kemudian petugas kesehatannya sebenarnya nggak ada tapi dibilang ada, seperti itu. Nah, kemudian ini kita punya untuk semua petugas kesehatan yang ada di puskesmas tersebut, seperti itu. Nah, kemudian yang kedua kita juga bisa mengukur kemudian dengan self-reported historical dari absenteeism ini, yaitu selama 4 minggu terakhir. 4 minggu terakhir yang kita dapatkan dari wawancara langsung dengan petugas kesehatan yang tadi itu, yang baik yang hadir maupun tidak hadir. Nah, kita bisa melakukan juga yang terpilih kesehatan menggunakan data yang cross-sectional untuk paper kita ini. Nah, kemudian untuk presentasi pagi ini kita melakukan untuk mendapatkan kemudian correlate apa-apa faktor-faktor yang mempengaruhi kemudian absenteeism di distrik ini, interdistrik korelasi ini, korelasi ini seperti apa? Kita melakukan regresi logistik. Nah, dengan dependent variabelnya adalah kemudian hadir nggak hadir, yang cross-sectional tadi. Satu hadir dan yang kalau 0 tidak hadir. Nah, kemudian kalau independent variabelnya kita merupakan 3 kelompok dimensi yang pengaruhi absenteeism ini. Kita tidak menggunakan satunya lagi yang terkait dengan policy dan lingkungan dari kelembagaan ini, tapi tidak masukkan faktor ini ke dalam logistik kita, tapi kita pergunakan nantinya adalah sebagai masukan pada saat melakukan diskusi kepada stakeholder untuk menentukan pada saat melakukan membuat desain untuk intervensinya yang kita masukkan, yang kita sebutkan dengan operational policy barrier analysis. Nah, ini kita masukkan di sana komponen yang keempatnya terkait dengan kelembagaan atau terkait dengan lingkungan kelembagaan maupun policy. Nah, kita masukkan dari situ nantinya. Jika di sini adalah 3, tapi kita masukkan di aspek pada saat kemudian kita melakukan analisis bersama-sama untuk intervensinya. Nah, untuk setiap kelompok dimensi dari faktor yang pengaruhi ini, kita memilih sejumlah kemudian dari data review, kemudian dari diskusi dengan pengampu kepentingan di awal studi ini juga, kemudian dari pengamatan kita juga bahwa kita memilih sejumlah variabel dan untuk setiap kelompok ini. Pertama kali terkait dengan karakteristik dari individu itu, kita masukkan kemudian informasi terkait dengan gender, kemudian profesinya seperti apa, sebagai apa, dokter ataupun perawat ataupun bidan seperti itu. Kemudian terkait dengan status perkawinannya, sudah menikah atau tidak. Kemudian umurnya kita masukkan juga. Ini kemudian kita memasukkan juga bagaimana kemudian kalau kondisinya, kalau petugas kesehatan itu memiliki anak di bawah 6 tahun. Seperti itu, seperti apa? Kemudian lama pengalamannya dia bekerja sebagai petugas kesehatan, dan yang terakhir kita masukkan juga lah etnik etnik dan campuran dengan tempat lahir daripada petugas kesehatan ini. Jadi kita memperhatikan etniknya dari apakah Papua non Papua, tapi juga kita perhatikan bukan cuma Papua non Papua, tapi juga kita perhatikan adalah tempat lahirnya. Kalau misalnya Papua, tapi kemudian apakah lahir di sana atau non Papua, tapi lahirnya di Papua seperti itu. Nanti akan dijelaskan lebih detail hasilnya seperti Pak Jeb. Kemudian ada kelompok dari karakteristik daripada lingkungannya, ini menyangkut juga biaya untuk pergi ke, kita masukkan variabel biaya untuk pergi ke fasilitas kesehatan tersebut, ke puskesmas ini berapa. Kemudian terkait dengan perumahannya, apa terkait dengan rumahnya, apakah tinggal di puskesmas, perumahan yang disediakan oleh puskesmas atau di luar puskesmas, tinggal di luar fasilitas perumahan di puskesmas. Yang berikutnya juga kita perhatikan juga apakah kemudian tinggal dengan keluarga enggak si petugas kesehatan ini, kita masukkan kepada berkaitan dengan lingkungan. Kemudian dia memiliki enggak kemudian praktek mandiri di luar bertugas di puskesmas ini. Dan kita juga mengumpulkan beberapa informasi yang kita pikir mempengaruhi, di antaranya apakah dia ingin bermaksud untuk ingin pindah enggak dari lokasi tersebut. Kita akan masukkan juga bagaimana kepuasannya dia bekerja di fasilitas itu, kita kumpulkan kita masukkan sebagai salah satu juga variabel yang kita masukkan dalam karakteristik dari lingkungan. Dan terakhirlah kita memasukkan juga kemudian komposisi etnik daripada komunitas yang dilayani oleh petugas kesehatan itu. Apakah kemudian komposisinya adalah Papuan semuanya, sebagian Papua atau bukan Papua atau mix seperti itu. Nah, ini kita masukkan juga sebagai satu kriteria yang kita masukkan dalam kelompok karakteristik lingkungannya. Dan terakhir untuk kelompok yang keadaan puskesmas, kita masukkan cukup banyak variabel yang kemudian kita lihat apakah kemudian mempengaruhi enggak kemudian ketidakhadiran dari petugas kesehatan. Di antaranya apakah puskesmas ini puskesmas ponet atau tidak, apakah puskesmas rawat inap atau tidak, kemudian bagaimana berapa hari waktu bukanya dalam 1 minggu, misalnya apakah 7 hari atau kurang, kemudian jumlah dari desa yang dicakup oleh puskesmas ini untuk dalam wilayah jangkauannya. Kemudian bagaimana kemudian kondisi dari fasilitas kesehatan ini kita juga masukkan sebagai sebuah indeks, sebagai satu independent variable kita. Selanjutnya kita juga lihat bagaimana kemudian kondisi daripada komunikasinya, komunikasi dari jaringan komunikasi di wilayah tersebut, diantaranya adalah akses internet dan juga untuk sinyal telepon. Dan yang menarik juga dalam yang kita masukkan dalam studi ini adalah karakteristik daripada kemudian kepala puskesmasnya. Karakteristiknya seperti apa? Apakah mempengaruhi enggak ketidakhadiran daripada puskesmas? Ketidakhadiran dari petugas kesehatannya. Kita masukkan sebagai karakteristik daripada daripada puskesmasnya. Yang berikutnya kita juga masukkan dalam pertanyaan kita tanyakan apakah ada upaya-upaya enggak yang telah dilakukan oleh puskesmas masing-masing untuk mengurangi tingkat ketidakhadiran. Jadi kita masukkan juga sebuah indikator di sini ya, untuk yang mungkin mempengaruhi tingkat ketidakhadiran. Dan terakhir kita masukkan juga adalah supervisi yang dilakukan oleh Dinas Kesehatan Kabupaten Kota. Apakah mempengaruhi enggak ketidakhadiran? Kita mungkin melihat seperti itu. Nah, sebelum kita masuki hasil daripada logistik regressionnya, saya ingin menampilkan inilah tingkat daripada ketidakhadiran. Kalau kita lihat berdasarkan kabupaten kotanya, di sini terlihat sekali bahwa ada gap yang luar biasa antara setiap kabupaten kota. Yang paling tinggi itulah di Kabupaten Jayapura, yang paling rendah di Kota Jayapura seperti kita duga. Banyak yang kaget kemudian kenapa di Kabupaten Jayapura yang paling tinggi ya. Kemudian yang berikutnya adalah yang kedua tertinggi itulah di Kabupaten Mimika, dan yang ketiga. Pada setiap kabupaten diduga juga sebelumnya adalah kemudian bisa direka-reka, pasti juga penyebab untuk ketidakhadiran untuk setiap kabupaten kota, baik yang rendah maupun yang tinggi ini juga pasti berbeda-beda dugaan kita. Atau mungkin ada yang sama, beberapa yang sama, tapi juga ada jumlah yang berbeda. Nah, kalau berbeda-beda, ini artinya bahwa kebijakan yang diambil untuk menurunkan tingkat absenteeism ini pun mesti berbeda-beda untuk tiga kabupaten kota. Ya, barangkali tadi malahan kita berdiskusi, barangkali juga di setiap kabupaten kota juga kalau kita mau ke bawah lagi mungkin juga berbeda-beda. Kita bisa melihat itu karena memang banyak sekali faktor-faktor lain yang sifatnya sangat spesifik. Tapi yang jelas yang kita lihat pada saat sekarang ini adalah bagaimana kemudian interdistrik daripada interdistrik korelasi yang berbeda. Ya, apakah bagaimana korelasi untuk setiap distrik ini? Untuk sebagian saya akan berhenti di sini. Saya akan serahkan ke Pak Jeb untuk bisa menerangkan bagaimana kemudian dua bagian berikutnya hasil daripada analisis regresi logistiknya dan juga bagaimana penggunaan daripada hasil tersebut untuk pengambil kebijakan. Pak Jeb, silakan ya.
Not following in. Is it? Yeah, okay, it's working. Okay, if I wanted to present in Bahasa Indonesia, I would have had to spend a lot more time preparing for that. I could do it, but it will be much more clear in English. If anything is not clear, please feel free to ask any questions, stop me. It gets a little bit difficult to follow, perhaps. It's actually a bit difficult to explain. But as Ibu Wayan has so well explained, you can already guess from this large variation in inter-district variation in absenteeism rates that the drivers or the correlates of absenteeism probably are quite different in each kabupaten kota here. So that's what we sought to explore. And again, keeping in mind the purpose of this was a very policy-oriented purpose to identify workable interventions that would help to reduce absenteeism in these districts. If you, and I should say that we also did a logistic regression pooling across all four districts. And the results were quite different. And one of the reasons is because one variable might be significantly important in one district, but completely unimportant in another. When you put all the districts together in one model, it comes out as perhaps not significant. Or one district would have a variable where the impact of that variable was positive, and another it was negative. And the average of two shows that variable not to be important. So you might miss some important opportunities to influence absenteeism if you looked at it with just the pool data across the province. So we're going to take a look at some of those differences now. Let's see if I can. Great. Okay. All right. So we're going to follow the framework that Ibu Wayan just explained to us. The three categories: worker characteristics, the environmental characteristics that the health worker finds her or himself in, and the characteristics of the puskesmas. Now we included the health center head variables as a puskesmas characteristic as well. You might have thought about putting them in environment, but we defined environment as beyond the puskesmas. So looking at the worker characteristics first, a dot, let's see, does this have a pointer? Yes, okay. A dot such as these means that the variable in that district was not significant. We're not presenting the pooled regression results. We have them if anybody's interested, but I don't think they're very meaningful for reasons I just stated. Where there's 1+, such as here, that means the variable was significant in that district at the 0.1 level. So some might call that important but not significant. Where there are 2 pluses, it was significant at the 0.05 level, and 3 pluses means it was significant at the 0.01 level. One of the thing I should probably go through, then pluses doesn't mean it was associated with higher absenteeism, but I'll get into that detail. I have my little cheat sheet here that I'll be referring to. Okay, so as we can see, male health workers are not significantly more or less absent than female health workers. So what does this say? It says don't target gender as characteristic around which to design an intervention. It's not going to, have any differential effect. We look at profession. It was not important. Doctors, nurses, and midwives in these 3 districts were neither more or less likely to be absent than the other profession, except Wijaya, where it was significant, and the nurses were twice as likely to be absent as midwives and doctors. So the implication there is if the district health office wanted to target an intervention in Jayawijaya, they might focus on trying to understand why nurses are more likely to be absent than doctors and midwives, and design an intervention that addressed those policy barriers. Age was important in 2 of the 4 districts, not in 2 of the others. An interesting aspect is that in Kota Jayapura, it's the older workers, those above age 40, who are more likely to be absent. Whereas in Kabupaten Jayapura, it was the younger workers, 20 to 29, who were more likely to be absent. So again, you wouldn't target age the same. In 2 of the 4 districts, you would target age potentially as an intervention to address absenteeism, but you have to look below just the age variable and understand that there are inter-district differences in how age plays out as explanatory factor of absenteeism. Being married was a significant driver of absenteeism, again, in these 2 districts, not in the other 2. Being married carried a higher likelihood of being absent than being single. So we decided that the intervention should be, don't allow people to marry, hire only single people. Nobody liked that idea. Having children under 6 years of age, our rationale for including that was we thought that, particularly for women who, still in most societies carry the lion's share of the responsibility for caring for particularly young children, that female health workers that had young children might be more likely to be absent. And we found it was not the case in 3 of the 4 districts, but it was in Kabupaten Jayapura. But the effect was opposite what we thought it might be. Those with children under age 6 were less likely to be absent than those without children under the age of 6. So then you have to contemplate, why might that be? And that was kind of the thing that we wanted our district health partners to discuss and debate in the operational policy barriers. So what would be the operator on, and I guess the other thing is give every health worker a child under the age of 6, right? And they'll be less likely to be absent. Okay, oops, excuse me, wrong button. Sorry about that. Okay, wanting to transfer. Again, this was a variable we thought might be associated with higher level of absenteeism, somewhat related to worker satisfaction. And we found that it was not significant except in Jayawijaya, where it was weakly significant, or important rather than significant. But again, opposite what we expected. In Jayawijaya, if you wanted to transfer, you were less likely to be absent at the time of the interview. And so again, the question is why? Maybe those who have a freewheeling head of the health center who doesn't really monitor absenteeism, they want to stay right there because, there's not much accountability. Or it could be those who want to transfer are trying to show that they're good workers and worthy of being transferred. So again, trying to understand why that is might help us to think about whether we want to use this variable. Ethnicity was very sensitive, and in our policy dialogue sessions, we had several of them, and we created 3 categories for this variable. We combined ethnicity with place of birth. So the first category was Asli Papuans, and there were none in our sample that were born outside Papua. So it was Asli Papuan born in Papua, non-Asli Papuans who were born in Papua, and then there would be the people who were not born in Papua, all of which were not Papuan. So 3 categories, and so not significant except worker. So again, you wouldn't target ethnicity or place of birth in terms of a queue about who might be more likely at higher risk to be absent any place but Mamika, according to this data. Okay. Moving to the environment characteristics. Well, let me just go back. Sorry, I wanted to make one more point about this slide. So if you look at the patterns by the column, you see Mamika, only 1 out of the 7 worker characteristics are significant. So it seems that in Mamika, worker characteristics may not be the best way to go in terms of thinking about how you're going to reduce absenteeism. However, in Kabupaten Jayapura, where 3 of the 7 variables is significant, seems that worker characteristics is a bit more important, and you might have better luck in looking at the characteristics of the health worker and designing an intervention. Okay, moving on to environment. We tested distance or time to the health center as well as fare. The time dimension didn't matter. We tested them independently because they're very highly correlated. Fare performed much better, but again, only in 2 out of the 4. In Kota Jayapura, you wouldn't be surprised, you know, the fares are fairly low to get from the workers' home to the health center. Jayawijaya, Mamika, it was important those with that paid more and had what we called a not low fare were more likely to be absent than those who paid less. Topographic condition, here we're basically comparing, so for example, in Kota Jayapura, there are some puskesmas that are located more remotely from the city center. They're a little bit more difficult to get to. I think they're mostly coastal, so you have to go by boat. And in Jayawijaya, obviously, the distinction here is more between mountainous puskesmas in mountainous areas and those that are not in the mountainous areas closer to Wamena. So curiously, in Kabupaten Jayapura, that distinction of, you know, whether it was in a more remote place or a mountainous or a coastal area, more difficult to get to or not, was not important, but it was important. The more remote, more difficult, more challenging geographic conditions predicted higher absenteeism. We looked at ethnicity, the predominant ethnicity of the community as well. So we categorize this as either predominantly Papuan, predominantly pendatang or migrants, and predominant and mixed. And so we can see the interestingly the category, I mean the composition of the community was important, highly important in all 4 kabupaten. But again, let me look at my cheat sheet. In Kota Jayapura, I think there were no communities that were majority Papuan. They were either majority pendatang or mixed. And those who were not mixed communities in the catchment area, the puskesmas were more likely, health workers were more likely to be absent than in puskesmas that served a mixed population. Again, what to make of this is the food for the policy dialogue later. In Kabupaten Jayapura, those health workers working in communities that were predominantly migrant communities were much more likely to be absent than people serving predominantly Papuan communities, and that was the same in the other 3. So Kota Jayapura stands out as a little bit different from the rest, but the rest, absenteeism was lower when the community was mostly Papuan. Number of villages in the catchment area was important in only 2 districts, but the direction was opposite. In Jayawijaya, those health workers working in health centers, they covered a large number of villages, were more likely to be absent, whereas in Mimika, those that covered a small number of villages were more likely to be absent. And again, I'm not sure I understand why that is. Government housing really was not important except in Kabupaten Jayapura. And as you would expect, those who lived in government housing were less likely to be absent than those that did not. So again, if you look for patterns in this, you might say that you might do better in Jayawijaya and Mimika in targeting environment characteristics as an intervention for addressing absenteeism, less so in Kota Jayapura and Kabupaten Jayapura, where only a couple of those factors were important. Yeah. It matters, and as I said in the first one, in Kota Jayapura, if I remember correctly, there were no majority Papuan catchment areas, Puskesmas catchment areas. They were all either majority migrants or mixed. And those that were in, what did I say? Those in the majority migrant communities were health workers were more likely to be absent than in health centers that served a mixed population. And I guess that's kind of interesting because that would suggest there were, there's a mix of Papuans in those communities. So in each case, so in the other three, where the community is mostly Papuan, the health workers were less likely to be absent. So that's curious. And in Kota Jayapura, communities that had a mix of Papuans and migrants were less likely to be absent. Yeah, but there are some communities that are mixed, right? Wamena is of course fairly mixed. I think that one, the health centers that serve the immediate Wamena area would be mostly mixed. Again, this is regression, so it should take account of any other correlations, and you should be getting, if the regression is done right, a clean effect of this variable controlling for other things. Yes, Paidi. Yeah, I'll have to go back to our notes to get that detail for you if you'd like it. But I believe we collected that information as part of the qualitative interviews with the key informant, the leaders of the community, and I think it's mostly the community leaders where we asked that question. So there's some subjectivity in this, more than likely. I don't think there was a clean break. We didn't have a census where we had the ethnicity of each catchment area. I think that data probably would be very difficult to come by. So, yes. Security, feelings of safety in the community and in getting to and from the health center. So we measured it there. The only thing we measured that security related in the community was in the health facility assessment, the condition of the health facility, where we did measure physical security of the compound itself. And so that's, in terms of other analyses we could do on this data, that's one we could take a closer look at. We did not decompose. We created a scale for the health facility condition, and we also created a scale for the health workers' satisfaction. And we didn't decompose them for this analysis, but we could take a closer look at that later. My sense is that health workers very rarely raise that as a major concern. Curiously, the community is actually, when we ask them why health workers are absent, they raise this more commonly. Said, health workers, are afraid of coming to the area. They're afraid of conflict. Obviously, that was more the case in Jayawijaya and Mimika than in the other two districts. So we also have a really interesting analysis to compare community perceptions of absenteeism and the reasons for it. We actually did that in the report that SurveyMETER submitted. We have some information about differences between communities' perceptions of absenteeism and the reasons, and what the health workers state. Keeping in mind that actually, and that's another interesting finding, the communities, and we have this, we're coming to the, we're jumping to the conclusion right now, communities seem to be more in tune with the results of the logistic regression than the workers. The workers will always tell you, saya sakit, keluarga saya, anak saya sakit, you know, ada acara di keluarga, you know, they'll tell you a reason that is not necessarily the real reason. The real reason, if you look at it, is, you know, they don't want to spend that much money. They don't want to spend that much time. You know, the condition of the facility is poor, and things of that nature. The community is kind of zeroed in on those real reasons. Okay, does that address your? Okay, so let's move on to the last set of characteristics, the health center characteristics, and I'm just going to flash up there's 2 slides here. These ones are more related to personnel and the health center head. You can see there aren't a lot of them that are significant. All of the interesting issues are here in this slide. So number of health facilities is important in 2 out of the 4. Again, the direction of the influence was pretty much the same. So those that are serving a low number, that have a small number of health facilities, sub-facilities, posyandu, polindes, were more likely to be absent than those that are working in puskesmas with a lower number of, did I just say that right? Yeah, and a lower number of health centers. Those that were PONET facilities, emergency obstetric care capable, that was important in 3 of the 4. And the direction was different in Kota Jayapura. Those that were not PONET were more workers in health facilities that were not PONET were more likely to be absent than those in PONET facilities. The opposite was true in Jayawijaya and Mimika, where those who were at a PONET facility were more likely to be absent than not. Again, perhaps it's because those that are at PONET facilities in more rural districts may be called more often to go outside the district, or maybe they had to deliver a baby in the middle of the night. We'd have, you know, that's something that you have to get the perspective of the district health officers who should know better about that. Whereas in Kota Jayapura, you know, they might not be as much of the middle of the night. There might be other places that the women deliver. Having overnight bed capacity was again important in 2 of the 4. And having no overnight bed capacity was associated with higher absenteeism than those that had overnight bed capacity. Being open 7 days a week versus less was predictive of higher absenteeism as well. So those that are working in facilities that are open 7 days a week were more likely to be absent. Again, could be because the scheduling is more complex and perhaps a little less regular and tiring. The health center condition was another cross-cutting variable that mattered everywhere, but there was sort of a difference. Kota Jayapura and Kabupaten Jayapura, those working in facilities assessed that had a low score on health facility condition were more likely to be absent than those that scored high. Health facility condition included the physical facility, the condition of it, maintenance, broken windows, lights that were missing. It included utilities, water, electricity, and how well they were functioning, if at all. It included presence of we call tracer equipment and drugs. Included an assessment of whether the drugs that were in stock were actually expired or not expired. And what else? I did include a couple of security questions, whether the facility was lockable and whatnot. And also, I think, cleanliness of the facility. So as you expect, those facilities that were in poorer condition, health workers were more likely to be absent in Kota Jayapura and Kabupaten Jayapura. The opposite was true in Jayawijaya and Mimika. Those that were in poorer, actually no, Jayawijaya is similar to the other two. Mimika, for some reason, health workers were more likely to be absent if they were working at a facility that had a high health facility condition score. Again, something to look at. Maybe they were more motivated because they felt a stronger passion to serve the community where the health facility was poor. I don't know. That's something to take a look at. Obviously, you would expect internet connectivity to not be an issue anywhere where none of the health centers had internet connectivity. You could only assess it in Kota Jayapura. Having internet connectivity was associated with lower absenteeism in Kota Jayapura. And that's a working internet connectivity. Mobile phone signal was relevant in all four. And in 2 of the 4 districts, it was important, and the other 2 not. And again, the stronger the signal, the less likely the health workers were to be absent. Finally, this set of slides. Curiously, the health center head was not so important. Some of these characteristics were not as important as we thought they would be, but the profession was important, differently in different places. And again, I think in 2 of these districts, there were no doctors as Puskesmas head. But in, let's see, what are they here? Kota Jayapura, those health centers that were led by a non-doctor, nurse, or midwife, and they were usually a public health professional, the workers were more likely to be absent than in those that were led by a nurse or a midwife. There were no doctors running health centers in Kota Jayapura, if I remember correctly. In Kabupaten Jayapura, if the health center was run by a nurse, health workers were more likely to be absent than if they were run by a midwife. Again, there are no doctors running health centers in Kabupaten Jayapura, if I remember correctly. And in Jayawijaya, those that are run by midwives have a higher likelihood of the workers being absent than those that are being led by other kinds of health workers. Yes. We have that data. It would be interesting. We didn't include it in this analysis, but that would be, that's something we could add in to take a look at that. We do have that, right, Ibu? Okay. Interestingly, whether the head was absent or not absent, we thought that might help to, predict absenteeism. It did only in Kota Jayapura, but guess what? Where the health center head was absent, the health worker was less likely to be absent. Maybe, so explain that one. Well, this is, we'd love to have some resources to look more deeply at some of these issues. But again, not all of these came out in the policy barriers, operational policy barriers dialogue workshop, because they went where the district health leaders wanted to go. And so they didn't obviously have time to look at every one of these. So we could design some additional sessions if we wanted to look specifically at the drivers of some of these things. And finally, we thought that having no doctor, lab tech, or a pharmacist might be important, but the only place it showed up as important in Jayawijaya, where if they had no lab tech, absenteeism was higher. Part of this is because, relatively small number of Puskesmas in each district. I think most of them probably have no pharmacist. And so that went in, what we found is that people usually very easily compensated for the lack of a pharmacist. They just assigned a nurse or a midwife to take care of that function of dispensing the medicine. A little bit more difficult to compensate for not having a lab tech. I have a little interesting story. Looking at one of the health facilities, went into the lab, we looked around, it was really filthy, and there was nothing in there. And so we said, okay, we went on our list. Do you have this? Do you have that? Do you have a microscope? Oh, yes, we have a microscope. And we're going, well, we're looking at the room right now. There's no cabinets, and there's no microscope. And they said, the lab technician took it home. So it's like, okay, that's really helpful. And the last DHO supervision visit, on bivariate analysis, it looked like it was going to be important. Those that had a more recent visit were more likely to be absent. And that might make sense. They wouldn't expect another DHO visit for a long time. So, they could loosen up a little bit. Well, in the multivariate, it shows up as not significant. So you have to be a little careful in using the bivariate results. Was one of the lessons here. Okay, so how did we use the findings? I'm just going to run through these very quickly. This was a very kind of complex set of policy dialogue sessions. This operational policy barriers chart here was produced. It's a bit old now, 2001, but this is when some of you in the room may remember the Global USAID Policy Project. It was mostly focused on reproductive health and HIV/AIDS. And when that project was in the process of transitioning from focusing on more macro national level policies to operational level policies that guide, the facility itself, or at the district level, more local policies, things such as opening hours, things that the health facility may have some, well, actually in this case, it's maybe an informal policy, but the fact, as Wayan said, that facilities were open at 8, but they didn't really require the workers to come in much before 9. And the fact that they were supposed to be open until whatever, 2 o'clock in the afternoon or so. I remember one health center we were visiting for the survey, and literally the people were crowded at the door at 11 o'clock because that's when the Puskesmas had let them leave. So that's an operational policy. It's a policy that's set by the facility itself. And it's something that you could perhaps influence. So you look at the environment, and you can see reflected in our framework most of these items here in one way or another. So what you do with the policy barriers analysis is you look at, so for example, these factors, what appears to be significant in terms of describing an absenteeism, and then you identify through dialogue what the operational policy barriers might be that are contributing to the absenteeism to that particular reason. So, for example, housing absenteeism is lower. So why is it not playing out in other districts? Because there isn't enough housing. The condition of the housing may not be good. You look at, and then you look beyond that. You say, well, the condition of the housing isn't good, or it's not sufficient because there's not money to build it or to maintain it. So those are operational level policy barriers that can be addressed locally. So they identify factors that they want to address, they think that are most important, have the biggest possibility of having an impact on absenteeism, and then they vet those possible solutions through their own relatively subjective analysis of feasibility. Politically feasible, will the district, will the Bupati agree to this? Will they sign, peraturan for changing a policy? Will the health workers buy into this? Then they look at monetary feasibility, financial feasibility. How much will it cost to implement this? So housing, we need to build more housing. Okay, fine, but how much is that going to cost? What's the likelihood that we're going to be able to get the money that we need? Et cetera, et cetera. And then so it's financial, managerial, and political. Managerial was, what do we have to do as a district health office in order to supervise implementation of this, and do we have the resources to supervise this? It comes out in a little bit different place. So we just wanted to share with you a few of the differences across districts. We haven't listed the districts here. So poor job performance of the health center, that's how some of the districts define health center head characteristics, and their assessment of the driver. In some places, they said they wanted to address it from a perspective of a lack of clear performance standards, some from a leadership capacity angle, and some from rewards and sanctions angle. And so the operational policy solution is appropriately different based on the barrier that they think is contributing to the poor performance of the health center head. Likewise, high fare for health workers to get to their health center. In Jayawijaya, I think this one is Jayawijaya, they felt that everybody got the same subsidy for transportation. It wasn't very well targeted, those that needed it more did not get more. They needed an interesting thing here is the subsidy was put right in their monthly paycheck. It wasn't even identifiable as transportation subsidies. Actually, I would give us a transportation subsidy for the fares. And when we health officials in Jaiwijai, they said, "What are you talking about? We already give them a subsidy." And finally, DHO provided was also covered, but guess what? The vehicle was managed by the district health office and not always available when the health back in winter. So the idea there was to transfer management of that vehicle to the Puskesmas health office. Finally, issue was the poor health facility condition. In one of the districts, they defined it as the barrier as being poorly coordinated planning, and another in poor guidance and support from the district health of making sure that the health center received its timely fashion. And in the other district, they issued a formal decree to establish an integrated evaluation team. Okay, some observations. Well, I think many of these lines already covered. The time of day greatly affects the rates. If anything, methods, we would given a skewed picture. You need to who are claimed to be working at sub-facilities. That's kind of related to this issue. The heads of the health centers are absent, and we did discover 50. They're here today. When he went out to the front, I remember one of the pilots. We went in, and okay, he gave us, the rundown. Now, sort of just sites, and he have time for this. He said, first thing, tell him we don't need to interrupt and verify the people. Back out. Back. Then we went back and said, okay, already, it was like 11 o'clock, I think. The registration lock. So we said the staff is sitting there, not doing anything. Ask if that person. I think the head is a bit frustrated because we found he didn't say no to that, and so we walked around. And we found that there were 6, and were in fact not. And had said we just said you weren't there. Can you tell us why? And half of it, I would say, at a post yonder. So it's really important to not take at base value and to verify what you're seeing both by walking on this issue, perspective on meetings, really matters. Allowed the excuse of training, but because it really, I mean, there's a lot of that that goes on, and I'm sure it's the same with teachers. It really detracts from the service delivery capacity. And you know, not that those seminars, trainings, and meetings aren't valid. They're happening, but I think people often look for lots of opportunities. This is nothing new to anybody in this room. So how you handle them matters also in what the rate is. How to count long-term absent providers. As Wayan suggested, the first thing we did, we walked in and said, is this health worker still here? Yes, no. If they're here, are they scheduled to be working now? Yes or no? One of the health centers, I remember, there was a nurse who hadn't been there for 4 months. And so if you ask, are they scheduled to be working now? The answer is no. They didn't count on her anymore. But she should be counted as an absent provider, because the reason she's not included in the schedule is because she's never included anymore. They just don't. Funny thing is that the first day we came to that health center, the health center was closed, so everybody was absent. Second day, what we did in those cases, the Wayan said, we told the community, okay, we're coming back. We didn't tell them what day. And of course, the word then goes out to everybody that works at that health center that can be, and most of them are reachable. And the day we came back to this health center 2 days later to go by boat from one of the coastal towns. And we got to the health center about half an hour, 45 minutes. The nurse comes charging up. This is the one that was absent for 4 months. Somebody from the coastal town ran to her house and said, they're coming back, they're coming back. So, you know, and we asked her, he said, oh yeah, I'm absent once a week because, you know, the market day, it's difficult to get a boat in this direction. So you have to really think about, you know, how to identify those long-term absent providers and whether they're being counted as scheduled or not scheduled by the Puskesmas head. Special arrangements, there were some health centers, one in particular I remember in Kabupaten Jayapura, where it was remote. There were 8 health workers assigned to that, doctors, nurses, and midwives to that health facility. Well, I think when we went there, only 4 were there. So they told us, well, we have an arrangement here. It's not sort of formally blessed, it's informally blessed by the district health office, where they would rotate. 4 would go in for 3 months and other 4 wouldn't. Who knows where they really are in those other 4, and then they switch. So do you count them as absent or not absent? In this case, we counted them as not absent because there was an informal agreement. And so, you know, whether that's right or not makes some difference too. And finally, as Ibu Wayan said, this was really quite amazing, the discrepancy between the rosters for the health workers at the Puskesmas. We had a consultant go in before the study, collect all the rosters for each Puskesmas by the consultant. The consultant collected them. That was the base that we approached each health center with. Only half of the people on average on that list were actually at the health center. The other half, some of them had transferred out, and you know, they all told us they had their SK, they had their formal approval to be transferred to another health center. Somehow that never got entered in the district health office list. And there were a large number of other workers who were formally and officially at that health center, posted at that health center, that weren't on the district health office list too. So you really have to take great care in confirming the roster, which creates your denominator for absenteeism. Okay, observations. These rates were not a surprise, even in Kabupaten Jayapura with, oh, sorry, okay. Yes, sir. Mm-hmm.
For one area in Mimika, Papa, we have also similar like in Kabupaten Jayapura. So it's not every 3 months, but every day, in 1 week. So they in one Puskesmas did they rotated, you know, if one person, they have arrangement that several people only we will go to the health center maybe Monday, Wednesday, and Friday. Something. The other head worker will just present in the health center during Tuesday and Thursday, for example, like that. So this arrangement actually, according to them, is already blessed by the Dinas Kabupaten Kota of Mimika. They know, but actually, what happened is they have what do you call they still absent in the city, in Timika city, but actually they're not present in the Puskesmas, because the distance is about 45 minutes from Timika city to the health center. So they actually, in the absent form, they listed as present. All of that, I forgot. It's like 15 head worker, you know. But actually, only 7 of them present every day.
to know who's used the connection to get approval for those special arrangements. The one that I'm more familiar with, I'm less familiar with the Mimika group in Kabupaten Jayapura, the one health center. You know, it's unlikely to have been political so much because it was 4 and 4, and it was a rotation. So seemed to be more expedient given the logistics of the location than political. But you know, we'd have to probably do more in-depth interviews in order to determine that. Okay. So again, as I said, even in Kabupaten Jayapura, he was not surprised. It was really kind of interesting. Well, the guy, the head of the HR, the district health office, human resources division, is kind of a very easygoing guy to begin with. So maybe he didn't look surprised because nothing surprises him. Well, in this one in particular, actually, yes, all of the districts, Jaya Wijaya, Mimika, they were not surprised. They were not surprised. In fact, they seemed to welcome the confirmation. The guy, the HR head in Kabupaten Jayapura actually, you know, claimed, he said, "I've been looking for evidence so I could justify doing something about it." When it's just anecdotal, you know, people don't want to listen, and with evidence, he to be more vocal about it. As we've already talked
Sorry,
about.
Pak Jeff, you only have 1 more minute.
Sure,
Finish.
we're just about done.
Just thank
I'm
you.
the second one we've already covered, the underestimate problem. We already talked about communities having good instincts and opportunity there to perhaps involve communities more in abatement of absenteeism. The issue of whether a reason for absenteeism is acceptable or unacceptable is really quite contentious. And so, you know, health workers don't have very good guidance on what's acceptable as a reason and what's not. And even the district health people had great debates about what was acceptable and what was not. So a natural disaster was a good reason, in their opinion, for not going to the health center. And I'm going, well, but what do you do with all the injured people in a natural disaster if they're allowed not to go to work? So, you know, there's some room there for work. And then we talked about the operational policy barriers dialogue, so I won't go into that again. future research, we wanted to leave you with this. Clearly, there's area for evaluation of the interventions that each of the districts decided they wanted to implement as a comment this data. There's a very rich set of additional questions that we could answer using the data set that we have. We intentionally collected a lot more data than we thought we would use in this particular analysis. And then clearly, I think the last national picture of health worker absenteeism is quite dated, and it's certainly not nearly as in-depth as this study. Would be very useful to get a broader perspective, particularly in light of the fact that there are clear differences by location in these issues. So, and finally, just leave you with one of the pilot districts. Beautiful little place. This was the place I mentioned earlier that was closed. 100% absenteeism when we went on pilot. The community is so clean, so well organized, and the people there in the focus groups were painfully aware of their rights to have health workers present. And were kind of they just didn't know how to go about insisting on their rights. The health center is closed as much as it's open in this particular place. It was very poignant talking to the communities to hear their frustration and to hear the frustration of the midwife who is Papuan from this particular desa, who is carrying the load. She opens the health center to get drugs 24 hours a day when she needs to. Everybody relies on her, while the doctors and nurses largely don't show up. And there is housing here, by the way. So I leave you with that thought and look forward to discussion. Sorry for going over time.
Terima kasih Wayan dan Pak Jeff untuk presentasinya yang sangat menarik dan informatif. Kita akan langsung masuk ke sesi diskusi dan tanya jawab. Saya buka untuk 3 pertanyaan pertama dulu. Ya, bisa tolong sebutkan nama, institusi, dan langsung ke pertanyaan, Pak. Terima kasih.
Ya, terima kasih. Thank you. I'm Sigit from the USA. So thank you for the very interesting research. So I've been looking quite a lot in Papua, so it's very interesting to get some of the confirmation of my observation during the day. I'm interested to more about whether there is an influence of the performance-based incentive currently happening in the Puskesmas, because with the current universal health capitation, right, at the one of the health workers is based on the. So I'm curious whether you see information perhaps during the qualitative interview whether this kind of performance-based incentive have an impact with rate in the Puskesmas. And I think the second one is the result of the study already being used to stimulate discussion at the district level, right? And then there's some follow-up action that already being done. So I think it would be good if this kind of stuff
ke Mbak Wayan aja ya, terkait dengan teknis di lapangan. Kan isu absenteeism kalau misalnya kita bilang khawatirnya informasi tidak keluar gitu. Nah, kalau di lapangan, tadi diceritakan juga kalau Ibu sampai observasi masing-masing ruangan untuk melihat apakah beneran hadir atau tidak gitu. Nah, apa pendekatan yang Ibu lakukan ke kepala puskesmas sampai akhirnya diizinkan untuk melakukan hal yang intens sensitif itu gitu. Mungkin sedikit berbagi dengan kami. Terima kasih.
Terima kasih Mbak Rika untuk satu pertanyaan terakhir. Tidak ada. Oke, Pak Asep.
Ya, kasih. Selamat untuk Bu Wayan dan Pak Jeb ya. Presentasinya menarik sekali. Juga studinya saya kira ini sangat tidak mudah ya pelaksananya di lapangan. So congratulations for the successful end. Saya
kita nggak kan bahwa pada sosialisasi tersebut kita kan tidak langsung kapan kita nggak bisa beri informasi bahwa kapan ke tanggal pastinya gitu ya, ke mas atau ke apa namanya untuk mengetahui bagaimana keadaan sebenarnya daripada puskesmas tersebut. Jadi ingin menanyakan, mereka juga ingin tahu setelah ini mau kemana lagi. Itu sangat-sangat apa namanya, mereka rasa kebersamaan dalam hal tanda petik begitu kuat sekali antar petugas kesehatan, ada antara petugas satu dengan petugas yang lain di petugas kesehatan sendiri. Nah, pada saat kami di Puskesmas itu, di Puskesmas adalah apa kita lakukan adalah kami mengatakan, oh ya kita tanyakan rosternya siapa yang kemudian dari ini hadir, apakah ada schedule-nya apa tidak, seperti katakan Pak Jep tadi. Kemudian kita tanyakan ada schedule-nya, oh ya ada schedule untuk di Puskesmas ini. Kemudian kalau ada schedule-nya sekarang hadir apa enggaknya. Nah, kemudian dia akan kepala Puskesmas atau yang senior yang di Puskesmas itu akan menjawab apakah hadir atau tidaknya. Kemudian kami mengatakan bahwa kami ingin melakukan melihat langsung bagaimana kemudian apakah memang benar ada apa tidak pada saat itu. Memang ada beberapa yang langsung mengizinkan, tapi ada beberapa juga mengatakan bahwa oh ya Kak, seperti tadi alasan yang tidak tidak secara langsung tidak mengizinkan, seperti oh ya sedang sibuk dan sebagainya. Tapi kami mengatakan kami melihat karena kami nanti perlu wawancarai. Salah satunya seperti itu. Karena memang nanti kita akan paling mewawancarai semua dokternya kan, targetnya untuk mewawancarai semua dokternya dan juga mewawancarai semua bidan yang ada di Puskesmas tersebut, dan juga kita mesti mewawancarai juga perawat yang ada di situ. Jadi salah satu yang kami pakai untuk alasan kenapa kami mesti melihatnya adalah untuk mengetahui si A, si B-nya yang mana adalah karena kita mesti mewawancarai petugas kesehatan tersebut. Walaupun untuk yang perawat kita katakan tidak semuanya seperti itu. Jadi itu salah satu alasan kemudian yang kita pakai kemudian untuk kenapa kemudian kita perlu diperkenalkan atau perlu mengunjungi ke ruangan-ruangan itu karena nantinya kita perlu mewawancarai para petugas kesehatan tersebut. Begitu Mbak. Ya. Jen?
So the next question from Pak Sigit.
Yeah. Okay, so there's several questions here. First, we did not look directly at the influence of performance-based incentives on absenteeism. We only included a variable that asked whether there was any active intervention or effort at the Puskesmas to try to reduce absenteeism. Curiously, almost all the health center heads said no. We're not doing anything in particular to reduce absenteeism. So I'm not very familiar with that particular performance-based incentive at the Puskesmas level. If it is tied to JKN, then this study preceded it was 2014, so they had just started JKN 6 months earlier. Wayan, do you have any perspective on that one?
No. It's not really, but during the field work, some of the head worker mentioned that, for example, because of the like we know that the number in the very remote area, the number of population is very small, and smaller than compared with the one in the city. So as for the head worker, it's more attractive that actually they would like to transfer to some of them to the city because of that condition, but not they just mentioned about the condition that's not many it's not attractive anymore to work in the very remote area because of the new policy related with the competition. Yeah.
Yeah, I think also just from a study methodology perspective, if you have an intervention like this, which is supposed to be operating at every health facility, then you wouldn't expect to see any variation in as a variable in an analysis like this, so you couldn't include it. To study something like that, what I would think you might have to do is to look at, you'd have to measure absenteeism at the Puskesmas before the intervention, and then you'd have to do successive measures after the intervention to sort of see if there was an impact, but that would be less at the health worker level Well, obviously you'd collect information about absenteeism at the health worker level. So it would be a different kind of data collection effort, not something that we would have done in a study like this, but a very
implementation is fine, even though it's like
yeah, right.
But it's of the Puskesmas, they implemented differently.
Right, and so that would be a rich area for a study to find out if, not just the approach to implementation, but the quality of the implementation effort as well would be important dimensions to perhaps take a look at. And there you could, compare and contrast health centers, even if you don't have a baseline. Your second point, I think, is a very, very interesting suggestion on creating a simplified methodology for communities to track absenteeism of health workers. I am not a full-time staff person or even a part-time staff person of Kinerja, Papua. There is a follow-on phase that has begun. I'm not intimately familiar with what they're planning to do, but they do quite a bit of work to try to empower the communities to influence basic services in their communities. They do have a complaint survey mechanism, and I believe absenteeism may be one of the issues that they address there. But it would be a very interesting thing to consider whether we could create some kind of a methodology and to think through how would that work? How would they know which health workers are showing up and not showing up? And how would they, you have to be careful there too. It's because the health worker is not showing up. You have to find out the reason, and it's so how do you create a simplified version that actually has an impact? Very interesting suggestion. I would suggest perhaps discussing that with the USAID Kinerja Papua grants manager, the person overseeing the study. Yes, yes.
I think really based on that complaint survey, some of the Puskesmas already responded to that. I mean, they opened the working hours longer. Even they provided morning and afternoon services. So they are based on the complaint survey done by the MSF.
Right.
They responded to that already.
That's great.
Yeah.
That's great.
And even not only that, they also since the user, the community observe on that. And yeah, then that is it's been addressed.
Great. Good. Pak Asep, your comment or your question about sample size, on average, each district had about 150 workers. It ranged, I think, from about 137 to 160 or something like that. So you can't then sub-analyze. That's, kind of, you wouldn't want to go lower than that. So you couldn't analyze doctors in each district or nurses in each district. Then the sample size is getting too large or too small. But I think 150 on average is enough to give you, credible results. However, that does not mean to say that the differences if you had a larger sample, that you might pick up some of these differences. Curiously, gender also, when you pool them all across the 4 districts, gender still doesn't pop out as important. So why? On bivariate analysis, the first analysis we did, the males did have a higher observed absenteeism rate. But again, you have to significance test that. And so when you did it by regression of course controls for the other things that might be related to being male. And after controlling those other variables, so male workers may be older, and so the real impact is being driven through the age variable and not the gender variable. And so what's coming out here is that it's not a gender driven thing, although on first view, it looked like there was something there. Yeah, I think those were the 2 questions you had. Yeah. Now, why it may be so, in the health sector in Papua, compared to perhaps you're referring to the teacher survey in Papua as well, where gender did look to be more significant. It would be an interesting thing to ask that question. Is there something different about teachers versus health workers that makes gender a correlate of absenteeism among teachers, but not among health workers? Yes.
Oke, terima kasih Bu Wayan, Pak Jeff. Kita buka sesi berikutnya masih dengan tanya jawab. Ada berapa pertanyaan? 3 orang yang ada 4. Oke, panitia kita masih punya waktu sekitar 15 menit. Oke, ini terakhir. Siapa tadi? Ya, oke, pertanyaan pertama Michelle, silakan.
Tes. Nama saya Michelle dari SMERU. Ini menurut saya sangat-sangat menarik, Pak, dan juga Ibu. Tapi ada yang mau saya tanyakan di gambar yang ketika mau bahas modeling logistic regression model ini kan ada banyak variabel. Lalu apakah yang tadi ditampilkan dalam tabel resultnya itu hanya yang menarik, atau emang ada beberapa variabel yang pada akhirnya tidak menjadi digunakan? Lalu ada yang ingin saya tanyakan khususnya untuk yang years of experience. Kenapa tidak ada? Terus apakah dihitung dari sejak lama dia menjadi health workers atau lama dia di puskesmas tersebut? Karena siapa tahu ada faktor senioritas. Mungkin yang senior merasa mereka tidak perlu rajin absen, seperti itu. Ya, terima kasih.
Terima kasih Michelle. Pertanyaan berikutnya Mbak Utari.
Terima kasih. Nama saya Utari dari SMERU. Saya mau tanya dulu tentang worker characteristics karena mungkin tadi saya agak miss memahaminya. Untuk di Kabupaten Jayapura ini, benar ya pemahaman saya bahwa mereka yang mempunyai anak di bawah usia 6 tahun lebih cenderung sering absen. Apa benar itu dulu, Bu Wayan? Daripada saya salah tanya itu dulu. Lalu kemudian ketika ini disebutkan more likely untuk absen, apakah studi ini juga melihat policy-policy yang sudah ada di kabupaten kota yang menjadi lokasi studi? Kemarin kebetulan saya baru bertemu kawan yang bercerita tentang pengalaman baik, best practices di Kabupaten Jayapura. Jadi di sana entah itu sudah menjadi satu policy atau baru kesepakatan tetapi sudah berjalan di Pemda Kabupaten Jayapura, mereka memiliki child care dan itu sangat membantu untuk mendukung ibu maupun bapak yang kerja dan membawa anak-anak di child care itu sehingga tingkat absenteeism-nya paling tidak kehadirannya menjadi lebih tepat waktu. Nah, saya jadi bertanya-tanya apakah kebijakan itu tidak juga diterapkan di pusat-pusat kesehatan masyarakat, karena kan sebetulnya itu masih bagian dari pemerintah kabupaten. Itu saja, terima kasih.
Berikutnya bisa langsung ke Mbak Titi.
Baik, nama saya Titi dari SMERU. Saya mau, jadi gini, kalau pengalaman saya pernah ikut studi absenteeism terkait dengan guru di bidang pendidikan itu, metode dilakukan mirip, bahkan hampir sama, cuman satu yang mungkin juga saya agak bertanya-tanya tentang kedatangan tim survei yang dibatasi pada saat jam 9.30 sampai 10. Apakah saya survei ini saya berpikir bahwa mungkin agak sangat punya toleransi yang besar tentang kemungkinan hasil, karena dulu yang kami lakukan itu selama jam operasional di sekolah. Kemudian tadi Pak Jeff sempat bilang bahwa ada kemungkinan ketika misalnya kurang dari jam 9.30 mereka belum datang, setelahnya mereka sudah pulang setelah 10.30. Nah, apakah di jam ini mungkin Ibu melihat bahwa di sana memang jam efektif dilakukan pelayanan? Apakah itu alasannya tidak hanya sekedar mentolerir mereka kepagian atau udah terlanjur pulang setelah siang? Kemudian yang kedua terkait dengan analisis hasil analisis yang tentang terkait dengan biaya dari rumah ke fasilitas kesehatan, ini kan yang punya nilai signifikannya di Jaya Wijaya dan Mimika. Kalau untuk pengalaman kami di bidang pendidikan itu, selain soal biaya, itu juga tentang kendaraan yang digunakan. Karena ternyata kalau tidak saya salah ingat itu untuk orang yang memiliki kendaraan bermotor, maksudnya roda 2, itu akan lebih mudah mobile untuk pergi pada saat jam operasional. Jadi tingkat kehadiran mereka yang memiliki kendaraan bermotor itu jadi lebih tinggi ketidakhadirannya, seperti itu. Apakah di sini juga dilihat sedalam itu? Terima kasih.
Terima kasih Mbak Titi. Pertanyaan terakhir untuk Bapak yang pakai jaket hitam. Ya, silahkan.
Ya, makasih. Menarik presentasinya. Saya terima kasih Pak Jeb dan Bu Wayan. Perkenalkan, nama saya Haris dari Reality Check Approach. Sekitar 4 bulan lalu saya pernah terlibat penelitian terkait performance monitoring dan accountability tentang KB dan reproduksi dari BKKBN, dan saya waktu itu di bawah UGM. Jadi ada ketertarikan dengan isu health center service, gitu, baik yang swasta atau negeri. Pertanyaannya, di sini studi konteksnya kan distrik kecamatan gitu kan, puskesmas. Di pengalaman saya kan, dan yang tadi saya simak, ternyata kan ada di level pustu untuk desa, pustu, dan terus polindes atau poskesdes. Apakah ini juga termasuk melingkup ke sana ketika dihimpun data di level puskesmas? Karena pengalaman saya berkunjung ke puskesmas juga kan bidan desa itu hanya transit aja untuk ke puskesmas, selebihnya dia ke pustu atau ke polindes atau poskesdes, dan di sana pun jadwalnya tidak normal seperti di puskesmas, jadi hari-hari tertentu saja, seperti itu. Dan mungkin juga jika dikaitkan dengan independent variables juga akan berbeda hasilnya jika melihat sampai ke pustu atau polindes atau poskesdes, seperti itu. Ya, di situ pertanyaannya. Terima kasih.
Terima kasih. Kita langsung ke pertanyaan pertama dari Michelle. Ada 2 pertanyaan ya tentang framework dan fee kalau tidak salah ya. Saya persilakan Pak Jeff ke Bu Wayan.
Jawab dulu di keempat penanya nanti. Ya, yang terkait dengan yang pertama sebenarnya nanti Jeb, I think maybe we miss one variable in the result, but kita membahas menampilkan semua hasil dari yang kita sebutkan dalam variabel-variabel yang ada di sini. Nanti mungkin Pak Jeb, the years of experience maybe we're not including in the
actually, let me explain that. Dropped them from the analysis because of collinearity. Years of experience was one of them. And we did collect data on years of experience at that health center and years of experience as a health worker. This was highly related to age, highly correlated with age. And when you try to include both age and years of experience, either way you cut it, the model doesn't work, can't use relation. So we tried the regression, dropping age and using years of experience in either way, and it was not significant. And then we used age independent of those variables, and it was significant, as we saw in 2 of the 4 kabupaten. So because you have to make a choice sometimes, particularly because of the relatively small sample size, it's not a big data set at the district level. Sufficient, but not really that big. So you have to make some tough choices when the relationship is high. So some of the variables that you see here, so private practice, for example, I don't know if we have it on this slide, but it was one of the ones that we tested as well. It was not significant, and well, actually, it was very little variation. Almost nobody admitted to having a private practice, which is something we have to think about if we're redoing this. How else can we ask that question? Maybe there's a better way to get a more honest answer. We kind of don't believe that most of those doctors have no private practice. But in any case, so some of the variables that are not there are because, of collinearity. Some are because there wasn't enough variation when we looked at the, the number of cases. Very good question.
Kemudian kalau terkait dengan kenapa kemudian kita milih tadi Mbak siapa ya, nomor kedua kali ya, Mbak Utari ya. Kemudian for the, we have to answer that one, Jeff. For the why, what is the?
It was one about the hours of interview.
Yes, the hours of interview. Yeah, okay, I can answer. Okay. Kenapa kemudian kita mewawancarai menetapkan jam 9.30 sampai dengan 10.30 untuk kita sebagai waktu di mana kita kunjungan kita yang pertama itu bukan kemudian dari sisi untuk mengefektifkan waktu wawancara kita, artinya ketika semua kemudian petugas kesehatan ada, tapi semata-mata kemudian biar tidak terjadi squid dalam hal ketidakhadiran begitu. Sehingga kita lebih kalau misalnya kita betul-betul datang awal banget itu bisa jeblok banget intinya. Jadi sehingga kita nggak banyak variasi yang terjadi begitu. Jadi kan bilang oh ya itu kan kita kan banyak berdebat kemudian pada saat itu. Jadi kita betul-betul kemudian kita tahu bahwa tadi bahwa kalau karena kita tetapkan waktunya seperti tadi 9.30 sampai 10.30 kita kan betul-betul mengetahui dengan pasti bahwa ini hasil pada saat kita berkunjung pada waktu tersebut. Kemudian kita tahu persis bahwa ini tidak underestimate karena kalau kita mewawancarai di luar untuk kunjungan menghitungnya di luar waktu tersebut, entah sebelumnya atau setelahnya pasti akan lebih tinggi seperti itu. Jadi semata-mata untuk menghindari adanya squid dan kemudian perdebatan dengan waktu bervariasinya. Tapi kita benar-benar ingin fokus pada saat itu seperti apa kondisinya sehingga lebih lebih bahwa kita tahu persis bahwa ini terkait dengan ketidakhadiran faktor-faktor lain yang menyebabkan kemudian bukan karena terlambat dan seperti itu ataupun pulang lebih awal ya yang kita banyak amati di puskesmas terjadi. Kemudian terkait dengan kemudian analisisnya jenis kendaraan. Okay, the type of the.
Before you go on to that one, can I add something?
Yes, sure. Yes, sure.
I think again, it's a very important point, and it's important to recognize that we just measured absenteeism at the height of presence. So again, this doesn't really describe the full extent of the problem of absenteeism. If we could study it, if we had the resources to do it a little differently, more comprehensively, what I would have done is recorded the time that each health worker arrived. So I would have sat there from 8 o'clock until, well, we wouldn't have to sit there after 11 or 11:30 because they would all be gone. But ostensibly, have someone record the time of arrival and the time of departure of each one, and then you can sort of create sort of an absenteeism rate by hour at the health center and really get a sense of the extent of the undersupply capacity at the health centers. But we didn't have that luxury in terms of resources, and so we chose to choose. And the other thing is that communities are very aware, and these health centers, it's not like one day most people are there at 8 and then another day they're there mostly at 9, and there's fair consistency in the habits. We get up in the morning and we tend to get up more or less the same time. We get out of the house more or less the same time. We get to work more or less the same time, whether it's early, late, or not, or on time. And so the communities are quite aware of the hour that they're most likely to find a health worker there. And so we chose that hour to measure it. Ideally, as I said, if anybody has resources to study it more comprehensively, please let us know. We'd love to do that kind of a study. I'm sorry. So transportation. I'm sorry.
Yeah, for the transport, untuk jenis transportasi kita.
Untuk jenis transportasi, kita nggak mengumpulkan jenis transportasi yang dipakai oleh petugas kesehatan. Tapi ini menarik sekali sih kalau misalnya kita dapatkan, mengumpulkan ya informasinya. Jadi kita tanyakan kemudian biaya yang kita tanyakan terkait dengan biayanya, biaya yang dikeluarkan oleh petugas kesehatan untuk menuju ke ke tempat kerjanya. Kemudian kita tanyakan juga sebenarnya adalah waktu yang dia perlukan seperti itu. Tapi kemudian kita memilih dalam analisis ini menggunakan biayanya karena ini lebih kelihatan seperti itu ininya, sebuah proksinya. Tapi menarik untuk lihat juga jenis kendaraan yang dipakai seperti itu. Jep, you like to add some? Ya. Kemudian dari sisi tentang petugas kesehatan, Pak Haris ya seperti itu ya. Petugas kesehatan yang mana aja kita yang mana aja kita cakup dalam studi ini. Jadi semua petugas kesehatan yang bertugas di wilayah puskesmas tersebut sebenarnya. Jadi kayak seperti bidan di desanya ataupun yang bertugas di Polindes atau Pustu, dia akan absen di puskesmas. Ya. Nah, jadi kita punya pertanyaan pertama kali kita pastikan dulu apakah petugas kesehatan ini adalah memang ditugaskan di puskesmas di puskesmas ataupun di luar puskesmas ini atau di wilayah jaringan dari puskesmas tersebut, di antaranya puskesmas pembantu ataupun Polindes, Poskesdesnya. Jadi kita tanyakan, oh ya dia memang bertugas si A, si B ini bertugas di sini. Kemudian berikutnya kita tanyakan, apakah kemudian petugas kesehatan ini adalah dijadwalkan untuk memberikan pelayanan di puskesmas ini, begitu. Ya. Jadi kita punya, apakah kalau iya, baru kita tanyakan, oh ya iya ini dia bertugas di puskesmas ini. Kalau ada juga yang tidak, oh ya dia tidak dijadwalkan di sini, tapi dia bertugas di puskesmas pembantu. Nah kalau itu, kalau seperti itu kita nggak tanyakan, yang kita tanyakan kemudian adalah yang bertugas di puskesmas tersebut kita tanyakan apakah hari ini hadir atau tidaknya. Nah kalau bagi yang hadir kita kelompokkan sebagai petugas kita yang hadir pada saat itu untuk kita wawancara. Kalau yang untuk perawat kita akan sampel kan, sedangkan yang tidak hadir kita kelompokkan sebagai nggak hadir dan kita untuk perawat kita sampel. Sedangkan untuk dokter dan juga bidan kita lakukan sensus. Sedangkan untuk mereka yang bertugas tidak dalam schedule-nya untuk bertugas di puskesmas pada hari tersebut, kita juga kalau dia dokter atau kalau dia dokter maupun bidan, kita akan wawancarai juga, tetap wawancarai, tapi walaupun dia tidak melakukan schedule hari itu di puskesmas tersebut ya. Tapi kemudian bagi yang bagi yang perawat kita akan kelompokkan dia, tetap kita akan sensus juga. Karena tadi Pak Jeb katakan tadi bahwa ada beberapa yang dikatakan bahwa dia tidak ada schedule di puskesmas tersebut, tapi ada schedule-nya di luar, artinya entah di Posyandu ataupun di Polindes, puskesmas bantu. Ketika kita temui ya untuk yang dokter bidan maupun juga yang sebenarnya untuk perawat semuanya kita sensus sebenarnya. Kalau yang dikatakan bertugas tidak bertugas pada saat di puskesmas pada saat itu, tapi dia bertugas di jaringan puskesmas lainnya, itu kita wawancarai seperti kata Pak Jeb tadi adalah kita wawancarai, kita tanyakan kenapa nggak hadir pada saat kita berkunjung, kita sebutin tanggal sekian tidak ada di puskesmas, kenapanya. Dan sebagian besar dari itu mengatakan bahwa dia sebenarnya bukan karena bertugas tidak ada schedule di puskesmas tersebut, karena kemudian bertugas di Polindes atau puskesmas bantu atau posyandu, tapi kemudian karena alasan lain sebenarnya. Seperti tadi misalnya ada urusan keluarga dan lain sebagainya ya. Ini cukup banyak, ini juga satu hal yang menarik untuk kita pakai. Jadi sebenarnya studi ini adalah mencakup juga petugas kesehatan yang memang ditugaskan di jaringan di puskesmas yang kita wawancarai seperti itu ininya. Saya pikir itu ya yang ininya ya.
Ada pertanyaan terakhir tadi dari Mbak Utari. She clarifies about the workers' characteristic. Is that true that staff with children under 6 is more likely to be absent than others? And then the second thing is about the existing policy in the study area.
Yeah.
Wijaya, it was important. Kids under 6, those with children under the age of 6 were less likely to be absent. But maaf ya, di Jayawijaya saja, Jayawijaya kan, Jayapura. Oh, di sini, let's see. Okay, sorry. Okay, my notes I wrote them down wrong. So yeah, Kabupaten Jayapura only. Kalau ada anak di bawah 6 tahun, lebih probable dia hadir. Kalau banding dengan kalau tiada anak di bawah 6 tahun. Kalau ada anak yang di bawah 6 tahun. Paham gak itu? So only one place it was important, and that was Kabupaten Jayapura. And if they had children under age 6, they are more likely to be present compared to those who.
So they're more likely to be not absent.
Not absent, right?
Related to because I read that there's a best practice in Kabupaten Jayapura that they have such kind of. I'm not sure whether it's a formal policy already, but at the district government, they already trying to accommodate the need of parents to have childcare facilities at the government compound. So I'm just wondering whether the good rates here is really related to the policy of providing childcare.
Yeah. Well, I did not visit all 57 or 50 of the health centers. I visited a number of them. Each one of us visited a number of them. I never saw a puskesmas that had a child care organized for the health workers. I'm not familiar, but we'd have to confirm it with somebody. My guess is that may be an innovation they're doing at the district offices, but not at the facility community level. I'd be very surprised if that's the case, but it would be a very interesting thing to see if that would be a useful intervention. I think you might look more closely at things like, so it might be that people that have children less than 6 years of age have made conscious arrangements for childcare, knowing that they have to go to work. And maybe those arrangements also take care of that child when the child gets sick. Or when they, have to take them to school or something else. It would bear sort of some more in-depth interviewing to find out why in this particular kabupaten it makes a difference. Yeah, okay. And the other question was which one? Itu saja ya? Okay.
That's all. Terima kasih Bapak dan Ibu untuk partisipasi aktifnya. Dengan ini forum kajian pembangunan hari ini sudah selesai. Boleh kita tepuk tangan dulu untuk para pembicara. Kami mewakili SMERU juga ingin mengucapkan terima kasih kepada Pak Jeff dan Ibu Wayan. Saya persilakan Pak Asep untuk menyerahkan tanda terima kasih. Thank you. Terima kasih Pak Asep. Ya, kami juga ingin mengundang Bapak Ibu untuk menghadiri 2 seminar FKP minggu depan. Yang pertama itu hari Selasa tanggal 20 Oktober 2015 yang akan datang dengan pembicara Ibu Atia Yumna dari SMERU dengan topik Local Health Financing Scheme or JAMKESDA in the Transition Time to Universal Health Coverage. Jam 10 sampai jam 12 di SMERU di ruangan yang sama. Dan FKP berikutnya hari Kamis tanggal 22 Oktober 2015 dengan pembicara Ibu Rahma Indah Nurbani dari SMERU dengan topik Changing Food Habit in Time of Food Price Volatility in Indonesia pada jam yang sama dan juga di ruangan yang sama di SMERU. Sekali lagi terima kasih Bapak dan Ibu, silakan menikmati hidangan makan siang yang sudah disiapkan. Terima kasih, selamat siang.